Okay, we are also, we can see you live. This is Ramesh Dagubati, Dr. Chandra. How are you doing? And Dr.
Yeah,
Arneja.
hi. How are you? Good.
I'm with my co-moderator, Dr. Arvinda Nanjundafa from West Virginia University. And we have Dr. Hong from Seoul, Korea, from Yonsei University, Dr. Alexander Knapp from Netherlands, Amsterdam, and Dr. Shaheen Pandi from South Africa.
Okay. So this is a fantastic international panel there, and I'm sure we will interact in a very positive direction. So, Dr. Ramesh, can you hear us clearly?
Yeah, we can hear you very clearly, loud and clear.
Okay. So let me just let you know that we are in Nagpur, and this is the fantastic heart institute known as Arneja Heart Institute, and none other than Dr. Arneja is already here. So Dr. Jaspal.
Yeah, you know, greetings from Arneja Heart Institute, Nagpur. I'm sure you're enjoying the great facilities at the Merrill Center there. And we are just ready with the case. I'll just give you a brief of the case.
Yes.
It's basically, he's a 83-year-old male who presented with acute LVF about 2 months back. And he's hypertensive. And on investigation, we found him to have severe aortic stenosis with a mean gradient of 68. And he also had a coronary artery disease, and which we have fixed his LAD with a PCI biomarker stent a few days back. The echo assessment of severe AS told us that the valve is tri-leaflet, and the mean gradient was 68 and the peak gradient of 109, and it was a critical AS with a valve area of 0.6, mild AR with a normal ejection fraction. Next. And he fell into a moderate STS score of 4.8. Next.
Intermediate risk.
And that falls into the intermediate risk. And his CT scan assessment told us that his annulus is about 19 millimeters, you know, both by perimetry as well as the and the area. So roughly it was more or less same. So telling us it is more or less circular. The eccentricity index was low, and the coronary height also from the annulus was 12 millimeters and 15 millimeters left and right. So that was also comfortable. And the sinuses are also roomy, you know, with about 26, 27, with more than 1.2. So favorable anatomy there. No calcium in the annulus, moderate calcium on the leaflets. So fairly good case. So, you know, that's how, you know, it's a 19 millimeter annulus there. And going by the MyValve sizing, we plan to put a 20 millimeter valve, which is about 12% oversized, which is perfectly acceptable. We want anything between 10 to 15% higher. So there we are, and Dr. Praveen Chandra is going to take us forward.
Okay, so this is the background that this patient is a severe calcific AS, and we are going ahead with TAVR in this case. So starting from the puncture. So first we go to the puncture, which side we want to take. So can we go to the first picture? Let's go live, Floro. And before I start, let me introduce Dr. Nagender Chouhan, who is in the middle of us, and he is even more experienced than me in doing TAVR procedures.
Yeah, we recognize
so we are comfortable over here, no problem.
Dr. Chandra is always modest, you can always see.
So now the question was which side we go. Now you can see something, that there is a tortuosity in the left side, because on the CT, as you saw the images, the tortuosity was seen more on the right side. So we decided we will go from the left side. But since at that time we didn't have the opportunity to see the raw images, we couldn't see this loop which was straightened up in the CT scan, which was a reconstructed images. Now when we injected from the other side, we saw that this is a big loop again over here. So we started thinking whether we will go from the right side or the left side, because both are equally bad. So we did a test. let me show you which test we did. Next, please. The good thing was that there was not severe calcification, so we started checking on the right side. If we have done the puncture high enough, we can go from the left side. But next shot. So we kept checking and we were not very sure whether we are at the bifurcation or above the bifurcation. So we RAO'd the view, we pulled the sheath up a little bit. So we are doing all these maneuvers to determine whether the puncture was above the bifurcation or not. Now here, next please. So what you see here is that it was just at the bifurcation. So we were not very comfortable again going from the right side. So we explored the left side again. Next please. So here you see that there is a loop. Next. And next. So we put the sheath, punctured this, and then we tested this by putting a stiff wire and tried to see whether it is straightening up or not. And we saw that it straightened up very easily, and the artery was not very fibrotic, not very calcific. So we thought that it may be reasonable to go from the left side also. So this was a test. Next. So then we took a super stiff wire, and then here you see that 18 French sheath was first inserted to see whether the access is going to be okay or not. It went off easily. Next. And then we took a 22 French sheath, which is the actual sheath on which the procedure has to be done. So this is why we were spending all the time very slowly to go inside this artery, because if there is a mess up here, it will be a real trouble. Next. So fortunately, now you see that the final 22 French sheath is going slowly. It was getting a little caught up. We did some twists and turns, and then slowly the sheath moved inside. The patient has remained stable since the last about 20 minutes. So we are comfortable. The groin is okay. So
and you pre-closed.
Sheath 22 French is in position. And
yeah, we have pre-closed it. Patient
we have pre-closed it already. And also we have put a 18 French sheath inside this 22 French so that we can do the balloon dilatation through this, and there is no oozing from this. Because as you see, there is a big clip over here in the sheath. So it's a very different kind of sheath which we are using in this patient. Now, we have put a pigtail, which is a 5 French. You can go to the next shot, please. Or I'll go to fluoro. I'll go to the fluoro. Fluoro, please. Yeah. So you see that the pigtail is in the non-coronary cusp, quite deep below, because you can see the calcium. And a pacing lead, which is again a 5 French pacing lead, has been used for pacing purposes. So everything is in position. We have not taken any shot as such because we still want to conserve dye. That femoral shots were absolutely necessary. So that's why we had to take that risk, because if you remember, this patient has a creatinine of 1.6. So I don't know the GFR. How much is the GFR?
The GFR is very
35-40?
35-40.
Yeah.
35.
So about 35-40 is the GFR. So our total contrast load we are aiming at is at 40 ml, complete.
Perfect.
Okay, so now we are going to take, this is an AL1 catheter, which we are taking to cross the valve. And wire, please. Okay, so we are going smoothly. I can't see this. Huh. Okay. Okay, straight. So now this was a J-tip Teflon wire. Now we will take a straight tip Terumo wire, which is exchange length, to cross this wire, this valve.
So and the patient is under conscious
fairly
sedation.
Standard
normal
method.
Teflon exchange length.
Yes, absolutely. Patient is under conscious sedation. And he is quite comfortable. The BP is, how much is the BP?
150 by 50.
150 by 50. So, and the rhythm is sinus, but rather slow. 52. And the QRS is narrow to start with.
And we also don't see a first degree AV block, which Dr. Arvinda was talking earlier, are all the predictors for permanent pacemakers.
Yeah, so we don't have any first degree AV block or any RBB for that matter.
QRS is quite narrow. So
QRS is narrow.
And you have already fully anticoagulated him.
Yes, now we have given 7,000 heparin.
All right.
how much is ACT? So ACT,
ACT
is
is
319.
This is Alex Knapp from the Netherlands. While you are poking and hoping, might I ask something about the closure of the groin? Are you using a closure device or ProGlide? What
Two
kind of
ProGlides.
closure?
They use the
ProGlide. 2 ProGlides are used.
Yeah, pretty close.
फंसा हुआ है इसमें.
उसको डाल दिया आगे, फिर बाहर डाल देंगे दूसरा. Yeah, नहीं.
A heavily calcified valve.
That's it.
ठीक है, ये निकाल दो. इसका हाँ, चला गया.
उसको अंदर शीट कहाँ से?
और शीत के चक्कर में छोटा पड़ रहा है ना. Okay, so we have crossed. We will do some hemodynamics now. If you say,
Yes, sir.
वहाँ चला.
Pressure or na? We have one more pressure, sir. We have another pressure.
you have another line. Okay,
Naresh, your pressure line ready?
so hemodynamics.
Some flush.
Can we have both
Both the pressures.
Okay. So the LV pressures are 157, around 170. And the arterial pressure is how
Pressure
much?
ठीक नहीं है.
1?
No,
140.
no, something wrong.
So it is 180 and 650. 140. So the gradient is 40.
186.
Okay, now I am going to take a exchange length Teflon wire to put a pigtail catheter inside. So this is our usual routine for all kind of valves, whether it is balloon expandable or it is a self-expanding. So Ramesh, is this what you also do, or if there is anything you want to say at this point?
No, I think everything is going very well. I think this is
Pigtail.
a very small
RO, please.
valve. Patient is 82 with the small annulus, heavily calcified.
I don't see the pressure on this.
मुझे pressure ठीक नहीं आ रहा है. So there's something wrong.
प्रेशर दिखा दो इससे, इधर राइट वाले से.
हाँ,
इसको फ्लश कर देता हूँ.
मैं flush करता हूँ.
I'm Pam Ki-hong from
So flush
South
करना
Korea.
अभी करता हूँ.
Is there
एक
any
मिनट.
issue of the subbarrel structure such as basal septal hypertrophy and so on?
Dr. Chandra,
There is no major septal hypertrophy.
There's no asymmetrical septal hypertrophy. It's a concentric hypertrophy.
वायर वायर दिखाना, वायर भैया.
Naresh, wire.
Okay, so my pigtail is almost there. Yeah, it is there. Okay. So the pigtail is there in position, and now is the time for me to put the super stiff wire, which is already angulated. As you can see, Nagender is doing this angulation using the introducer, which is very helpful. And before this, now I want to make sure how far are we in the sense of valve being ready. Valve is ready, the balloon
Balloon is ready.
ready. So we make sure that everything is there ready, because sometimes if you keep this wire for long time in the ventricle, such heavy duty wire, it can really
is that a Lundaquist?
tear the ventricle if it is there for long time.
This is Amplar's extra stiff wire.
Extra.
Okay. It is quite a strong. This is not a Confida type of wire. It has a very strong tip, so we have to be very careful because the transition is small.
Yeah. So we actually try to make the curvature involving the transition period as well, but unfortunately, or fortunately, we stopped actually doing any of these because of we have now pre-shaped wires and Safari, and we are very comfortable using them.
Yes, so normally we use the Confida wire, but since here we are starting this program, so Metronics has not supplied the Confida wire as yet. They don't want also, as you can understand.
So that's we should really thank Merrill and Dr. Arneja to show this live case of for my valve.
Yeah, of course. Yeah. So this is a 16 millimeter balloon we have taken. So there are two purposes of doing this dilatation today. One is that the whole team unit will be knowing the exact drill of doing the pacing, and we'll check the pacing also. And the second is that since it is a very tight valve, we won't have too many hemodynamic issues while the valve is in position.
There we are. Be ready with that.
Okay. Okay. So when I say, okay, who's ready? Ready? Oh, you are ready? Yes, come here. Come here. ठीक है? Okay. So pacing on. No, just on. Just stop. I don't see any pressure over here. First, let me see the pressures.
क्यों नहीं आ रहा है?
Flush करो.
Flush. ये zero flush करो जो भी करना है इधर.
It might be damped.
So zero करो.
Yeah.
So we are just checking that because the pressure is available on the other monitor, not in this monitor.
You're getting the
Flush
pressure from the side.
क्या आपके side?
Pressure, हाँ sir, pressure.
इधर से करो.
मैं कर रहा हूँ, खोलो. Open. Yes. No. Yeah, it's better. Pressure.
Are you measuring
No
pressure
pressure,
from
Yes,
the side
zero.
port?
Okay. There's something.
No, there is a radial line also.
Okay, so we'll see the radial line pressure is.
No, we have to. I want to see that.
इसको मैं फिर
इसको इधर से रेडियल से कर देते हैं. नहीं, आप छोड़ दो उसको. चलो, now
Possibly
दिखाओ.
it's hitting the wall or something.
Show me the pressure.
In the.
Now it is okay.
Nice, all right. Yeah.
Now the
The
monitor shows it well.
ECG is changing.
Okay, so pacing on,
Pacing on.
and the pressure has dropped.
Flow.
Okay.
Flow.
Okay. Balloon up. Balloon down.
Down, balloon down.
Pacing off.
Pacing off.
ठीक, इसको निकाल लो. Balloon. वायर को ध्यान से. So we have to be very careful. Wire. No, wire is getting pushed. Okay, fine.
So good recovery of blood
So,
pressure.
Yeah, the blood pressure is okay now.
Diastolic is
And
quite low.
diastolic is how much?
28.
30. Diastolic is 30. Huh? Okay, so we are ready now, and we will take this 18 French sheath out, and you can see the valve which is already mounted on this catheter, which they call it as the phantom. Yeah, phantom?
No.
A navigator.
Navigator.
So, okay,
Skirt is on the
and the
distance.
skirt is there on the distal edge, so it's all in the right position. Fine. Okay, so I will just try. Who will take this out? आप इसको
Okay.
इनको पकड़ा दो.
आप इसको
आप इसको hold करिए. Take this out. So we have to be careful because I will have to release the sheath a little bit.
आगे ला. It will bleed.
It will ooze a little bit because The valve has been dilated now.
Volume.
Okay. I will open the valve. Okay, I'm opening it up.
I think it's opened heavy.
नहीं, I'm opening it up.
Full open. Wire वहाँ पे floor.
मैं कर रहा हूँ.
खींच रहा हूँ.
Wire
Yes,
push
ठीक है.
करो. Wire.
Take
Bas that's it. You hold the wire.
Yeah.
Keep holding the wire.
Yeah.
There is some problem in the sheath.
This is the, I think, dry
No,
seal.
the valve is getting stuck.
The dry seal, you have to completely open it at least for a few seconds, and then you can inflate. I would,
Blood हो रहा है. Blood
Yeah.
चालू कर दे.
yeah.
Wire को अंदर करो. So I pulled it a little bit back
Yeah.
and then checking everything because I want this to be checked physically again.
Yeah, I agree.
Check it. Check the
Slightly
this thing
pushed.
mounting.
Blood.
Slightly pushed.
Please check it. एक sheet डाल दो इस पे sheet.
Slightly pushed, I think.
Give me a sheath on this.
Give me a sheath.
Otherwise it will keep oozing. Not like this. With
Okay,
the
yeah.
This one, okay.
Because these big sheets start oozing with the wire.
Yes.
So we put another one inside. So there is no hurry. We have to take our time and be very careful.
Floor. Floor.
And
Okay.
you're using transthoracic echo.
No,
as
that's
guidance.
okay. You want to do a transthoracic echo?
No, no, no. You're using that as a guidance, right?
Yeah.
For your-
अबे
Yes,
Yeah.
yes. So is the valve ready?
I see Imran is
So the
working.
sheath needs to be dilated a little bit. इसका इसी का dilator दे दो. Give the dilator of the sheath. हाँ. So what I'm going to do now is, before I take the valve again, I will dilate the valve of the sheath because sometimes these valves collapse. This is actually a very big sheath to start with, 22 French. So that's why I'm little worried. The It is going easily.
नीचे दिखाना.
So I am doing this. नीचे दिखाओ.
नीचे दिखाना.
It's okay. Okay. Fine.
So, ऊपर दिखा दो. ऊपर दिखा
ऊपर
दो.
ऊपर ऊपर wire.
Yeah, so I would
Okay, that's it. यहीं
zoom,
रखने दो, यहीं
zoom
रखने दो.
out.
आ जाने दो.
So for us, the early recommendations had been always zoom out so that you can see the wire as well as the sheath
Yes.
tip. Yeah.
Yes.
Both of them should be seen in one view.
Minimal zoom. Minimal zoom.
Yeah. So like
Minimal zoom है?
हाँ. Zero.
It's already zero zoom, so we are okay.
Floor करके देख लेंगे.
Okay.
20 and इसको कम कर.
So can we have this quickly?
अबे बुलाया ना.
He's doing another one. Okay.
So we are
Echo
doing
can
another
be done
valve.
now.
the patient had no AI before.
They wanted to see an echo.
No, he had actually some AI, right?
He had mild
Mild
AR,
AR.
grade 1.
This time it is quite.
But this time it is quite, the BP, the diastolic is 620, 22. So we have to be quick now
Yeah.
because maybe he will not tolerate that much. Although his LV is completely normal,
Yeah.
but still. And we didn't do a big dilatation, it was a 16 size.
Right. Any questions from Shaheen? Anything?
Yes, this is Shaheen Pandey from South Africa. I'm used to using the Edward Sapien valve. I find it interesting on the introduction of the valve that there isn't a protective introducer for the valve itself as it goes through the hub of the sheath.
So this is the Indian valve, the My valve. So it is not Edward Sapien.
Chalo.
Yes,
Okay.
I know. That's why I'm saying with this valve, I see there's no protective sheath as the valve gets introduced
Right.
through the sheath, the
Right.
valve of the sheath.
Exactly.
I just found that very interesting.
Right, and I think that's why the valve of the sheath, which Dr. Chandra just now opened it up again, has to be very much open. So there are several clicks on that sheath. You can click it to tighten it up, or you have to completely open it. So Dr. Chandra, what Dr. Shaheen Pandey from South Africa is saying is, normally for the Edward sheath, we have a protective cover about 4 inches long.
ऐसे नहीं जाएगा क्या?
Wow.
निकालना आपको लॉक करना होगा.
No, unlocked है. इसको नहीं, इसको चढ़ाना पड़ेगा
इसके
ना?
ऊपर जाना, वायर के ऊपर.
Holding.
Now he's opening up
So I've
the valve.
opened the sheath now.
Yeah.
Probably we'll have to change the sheath maybe. Yeah. Because the sheath is not behaving well. Because it is
It's completely opened up. Dr.
distorting the
Chandra?
valve. Yeah,
it's
it
fully
is fully opened up.
Fully open.
And the initial valve is slightly tight, so that's the system.
It's not going.
Give me a new sheet.
निकाल लो.
Float.
Give me a new sheath. So we are going to change the sheath because this valve is not responding well.
Okay.
So somebody has to come from that side. This has a clip on this.
Yeah.
So maybe this clip is the real
This is flashlight.
problem sometimes, you know. It doesn't release the valve that much. Can we have the new sheath?
So the
Now here there may be a little bit of an issue because we'll have to take the sheath out very, very carefully.
yeah, and the femoral artery size was how much on CT scan?
8.6.
8.6.
It was about 8.7. Common femoral 8.7.
8.7 to 9, yes, 8.7.
The artery size was okay,
Yes.
but the tortuosity is the issue. Okay, so you have to
Little
compress it
tachycardia.
from there. Slowly मैं निकालूंगा. Keep looking at the wire now.
Yeah.
Wire देखते रहो. तुम निकालो.
ठीक है, अब लगा के मैंने निकाला.
Yeah, it's very important to do millimeter by millimeter in these large sheets.
नीचे फ्लोर दिखाना पड़ेगा उसको.
इसमें propofol.
प्रोपोफॉल है.
वॉल्यूम फास्ट जाने थे.
ओके
नॉन मैग और हो सकता होगा ये।
नहीं नॉन मैग और नहीं हो।
फाइन, एक बार नीचे दिखाओ।
नीचे बताओ, नीचे नरेश।
ठीक, फाइन फाइन फाइन,
फाइन।
ओके ओके, निकाल दो। सो एक मिनट, वो वाल्व इज रेडी?
Valve is ready. Just a minute. Your valve is ready? He is just pumping one more time. Pressure is slightly
Slightly
Pressure.
low. Pressure is low. Naresh.
137 is not low.
Pressure.
137 but not low.
This is a little techie also.
You have to do it fast now.
Is he bleeding or what? No, because he may go into LVF. You might have to intubate him.
Valve is ready, I think.
देख लो, जरूरत है intubation की भी?
Pressure.
Deploy the
Not a
valve.
P. First day.
Yeah, we are doing that.
First.
इसको निकालो, नहीं निकालो, रुको,
The dilator
इसको निकालो। Yeah, I'm taking it off. Wire. जल्दी जल्दी।
No, sir.
इंटीबेट कर दो।
I think you'll be able to deploy it with
Straight up.
if it goes.
Holding? Yeah, valve is in now.
We've gone in.
Chalo, let's deploy.
Hold the wire, please.
We are holding, sir.
एक मिनट वो देना। Okay, LAO please.
Hello.
Enough.
Is there
Enough.
anything-
ऊपर
दिखाओ,
दिखाओ नरेश,
ऊपर दिखाओ।
ऊपर दिखाओ।
एक मिनट, ये दिख नहीं रहा मेरे को।
ठीक है।
कहाँ से ब्लड आ रहा है? He's bleeding from somewhere.
अभी ऐसे हुआ है ऐसे चलो।
No, ये खुला हुआ है, that's the reason. ये
Fuck.
कर दो आप इंटीबेट।
Pressure already.
It's okay, pressure is
now.
okay
I
now.
think we can wait for some.
We can wait. Sir.
Wire.
Wire.
ठीक है, आप इधर आ जाइए।
चलो इसमें आ जाओ, आ रहे हो?
RAO 4 cranial 7
RAO 4 cranial 7
नॉरेपिक कम कर देना।
cranial 7 RAO 4
ठीक, चलो
20 ml
20 ml
अभी
20
नहीं,
ml
अभी
dye
नहीं।
या
चलो वो शीट को
Yeah, so we have crossed।
I think on the right place.
एक मिनट, शॉट लेना होगा एक।
I think you're in a good position.
रेडी?
ready shot
प्रेशर कम करो।
pressure reduce the pressure reduce the by nitro
Shoot.
शूट।
It's a very good position.
we can
I think it's a good
I think
position.
we are okay।
show show
Can you reduce the pressure?
reduce the pressure
चलो pressing on
Pressing on.
180 shoot
One more 200.
one more shoot
200
shoot यार आगे चला गया थोड़ा सा shoot
Shoot.
one more shoot
नहीं
Pressure
अभी
is
नहीं
very high. We have to stop it.
pacing stop
pacing stop
Pressure is very high.
Pressure is too high. I think.
So you have to reduce the
reduce the pressure
reduce the pressure.
inotropes बंद करो
It's bleeding from here.
I know that they
ऐसा
were
नहीं तो नहीं हो रहा. ऐसा नहीं हो रहा.
नहीं हो रहा है
अब छोड़ी नहीं होता है. अब नहीं हो रहा.
ठीक चलो
No, bring the
Ready with the
pressure
Just
down.
less.
yeah we are trying to bring the pressure down
ये
NTG,
अभी नहीं, ये लगेगा
NTG.
प्रेशर लगेगा ये लगेगा
That's coming down. I think 160. Now it's okay. We can.
okay
थोड़ा
that's
सा
fine
और
the
हो
pressure
जाने
is fine now
थोड़ा और कम कर दो ठीक है फाइन
So
ओके
1% should be on TPI and one.
one on TPI एक जन इधर से आ तो फिर
अच्छा जब हम नहीं पेसिंग ये भी रेडी रखना इंजेक्टर
इंजेक्टर भी रेडी है
Pull भी करना.
हाँ वो मैं कर लूँगा
1% should be ready on injector, and one should be ready on pacemaker.
ओके थोड़ा
Yeah,
पीछे कर
deep
लेते हैं ठीक है एक मिनट पेसिंग ऑन 180 नहीं 200 200 no stop pacing the pressure is still high.
Yeah, pressure is high. I think give a
We have to bring down the pressure first.
yeah, give some time and no rush.
Pressure is
coming down.
It's coming
Yeah.
down. Just hold on.
Just hold
It's
on.
coming. It's 130.
Saturation is okay, patient is stable. Okay.
Yeah, I think AP has been given, so it has to wear off. The heart rate is also
Yeah.
just
Yeah, that's
no
why it's
no
not
rush.
coming
His
down.
blood pressure is good. He's tolerating
Why
it
को
well.
ध्यान से
While we're waiting, could I
Yeah.
possibly ask about the positioning of the valve? Is it just the center of the my valve that goes
120
across
तक
the
आ जाने
annulus?
दो.
Yeah. Sorry.
I'm just asking about the positioning of the valve, the my valve.
Can we check one position
Yeah.
one more time?
चलो check कर लो.
It's not by the mark.
10 ml dye.
10 ml
10
dye.
ml.
10 ml. Just a minute.
Ready?
Wait,
हाँ,
no, sir.
I'm waiting.
Sir, it's
Only
10 ml
10.
dye. 10 ml.
Okay, ready?
No, sir. Just a second.
हाँ.
10 ml only. Rate of
Inject.
shoot.
थोड़ा
This is-
ऊंचा.
This is
उसका पिकटेल ना थोड़ा सा.
slightly low.
Maybe one slightly low.
We need to bring down a little bit. ठीक है, okay, fine. फिर प्रेशर बढ़ गया.
NTG है given थे तो समझ.
NTG दे दो यार. First
Stop
कर दो.
epi also.
Stop epi.
Okay.
220 पे पेस कर
Give
दो.
some sedation. अच्छा, now it's fully sedated.
Full sedation कर दो. Okay. So
Okay, wait. It's very high.
अब कम आ गया. ठीक है.
Now it's coming down.
Okay, it's coming. Yes, coming down.
ठीक है चलो.
Heart
चलो
rate
पेसिंग ऑन. फिर हम बोलेंगे तो इंजेक्टर रेडी है.
Injector ready.
20 ml.
ओके इंजेक्ट.
Inject. No, it's not ready. Off.
Inject.
हाँ.
So it's okay. Now it's ready. So
अभी नहीं, अभी हम बोलेंगे नहीं. आप सब लोग इंस्ट्रक्शन मत दो प्लीज.
So there should be only
Go
one
up.
person speaking and
Pacing
Dr.
on.
Chandra's voice.
पेसिंग ऑन. इंजेक्टर
inject.
थोड़ा ऊपर है.
Start inflating.
नहीं अभी नहीं.
Pacing off, sir. Pacing.
Stop pacing.
Pacing.
स्टॉप पेसिंग.
Stop NTG also.
ओके.
Stop NTG.
आज एक बार और शॉट लेंगे हम. पेसिंग करेंगे.
Ready?
शॉट लेंगे. हैं? आप लोग पेसिंग बंद मत कराना अपने आप. मैं बोलूँगा जब ही होगा.
ठीक है.
ठीक है.
Okay.
ओके नाउ ये पेसिंग ऑन. इंजेक्ट. ओके रुक जाओ.
Pacing off. Pacing
गो
off.
अप.
Pacing.
नहीं
Negative.
पेसिंग.
1, 2,
3.
3,
4
4, 5.
5 डिफ्लेट. पेसिंग ऑफ. चलो निकाल लो उसको.
Echo.
Echo.
Blood check तो नहीं है. Diastolic is quite low here.
ये एक बार
एक शॉट ले लेते हैं.
हाँ.
हमने 10 ml डाय कितना चाहिए?
Pressure is lower
इसको
side.
निकाल लो. इसको निकाल लो. इसकी जरूरत नहीं है.
Pressure is on lower side. There may be some AR. We have to check it.
थोड़ा
निकाल लो.
pressure.
गिव सम वॉल्यूम नाउ.
Give volume. Check for AR.
एक shot लेके ले.
ले लेते हैं. इसको निकाल लो पहले.
It will take some time probably. to
Nikalo.
recover. Is the radial blood pressure also same?
निकाल लो.
Just check it.
विल चेकिंग.
Yeah. Yes.
pressures, थोड़ा increase करो AP.
Not a peak.
RV is very small, so you give some say volume. AR दिखाना यार AR.
Can you show some air?
Pressure increase करो boss.
Saline.
RV is very small. Give more volume.
Don't push. It's a saline then.
There is no.
No pericardial effusion. हाँ. ज़्यादा चीज़ से कुछ नहीं हुआ है Full bottle.
Yeah, last से volume दो यार और. Give him Axel or something like that.
आप ले लो स्ट्रे क्या देना मैं ठीक है मैं इसको दे
नहीं पहले saline push कर दो यार. Push it. इधर से दो. इसमें पिक्चर डाल देते हैं लोग. इसको चेंज करके पिक्चर डाल देते हैं. एक पिक्चर देना जरा.
Coming up, the pressure.
दे दो देते जाओ. या.
And nitro is off, right?
Yeah, nitro is off. The pressure is 80 now.
Yeah, I mean, I think it was a prolonged
Not too much of
pacing run, and so it'll take some time.
RV is increasing now.
Pressure is 95 now. 100 pressure.
Actually, it is more of a hypovolemia.
Yeah.
Suicidal.
Now it is 103. Blood दे दो boss, blood.
Yeah, I think now you can stop.
ये change कर दो यार. Saline कैसा है? I don't like the saline. Give some proper saline. बस ठीक है.
RV is now what size?
Now RV is okay.
Check that ER.
अब AR देखो जरा. There is no AR. No AR. So we can do a check shoot final and that should be it. I am taking a pigtail. Pigtail please.
Yeah.
Actually इससे हुआ. बोथ को जीरो करिए.
It's 50, so borderline.
On the echo, there is no AR. उसमें देखा plaques. कलर लगाओ. LV थोड़ा सा dilated सा लग रहा है. LV.
Probably from all the AI, but I think still the EDP is not high, right? The EDP is not high.
Yes. The ejection fraction looks okay.
Diastolic is 50. Yeah.
And some gradient is there, but probably that is not from aortic pressure. That's
I think, yeah.
LV to femoral pressure, right?
Basically, the peripheral pressure is coming from the radial, so there may be some difference.
Right.
I will check the pressure with the pigtail. We have a pigtail pressure
When you
in
can
the
take
aorta.
yeah, you can.
Flush करना पड़ेगा,
Yeah, we have a pigtail in the
Right.
ascending aortic
Right.
root, so we can check that pressure as well.
I think that'll be
Because
fine.
sometimes the augmentation,
Yes.
yeah, there is no gradient, zero.
You can see
Right.
there's no
Wonderful. Yeah.
4 or 5.
Almost 4, 5. Okay, so
We have to just check for AI if it's there and then
Yeah. You can
You
check
want to
for
take a
AI
shoot?
now.
you want us to take a shoot?
Yeah.
Not
Anybody-
necessary.
No, not. Some people are saying not necessary. How many people feel that echo is good enough? Which transthoracic they saw there is no AI, or do you want a aortic root shot?
So since we are not going to dilate this, I'm going to take the pigtail out.
Yes.
So whatever,
I would take the pigtail out,
we
and you're
see
worried
here.
about contrast, so I
Yes.
wouldn't even do a root shot. His creatinine.
yeah, that's right.
Yeah.
Okay. नहीं वहाँ चाहिए होगा ना? Okay, now you can check again. वायर इधर देना, इसको भी निकाल दें.
you have to swap it from anterior to posterior. Swap the aortic wall anterior to posterior, and if you can show us in short axis, that will be good.
So the QRS is narrow, and it's all sinus rhythm. So most likely you will not need any pacing.
I think so. I think this looks good. Any comments, Alexander?
Yes, I have a question.
Let's see the pressures.
About if you have some conduction delay and the patient is the pacemaker dependent, you put it to the CCU, and how long will you wait to give him a permanent pacemaker? In our lab, that's
So the
about
pressures
a
are
week,
quite
but
okay.
is there a
120.
general rule of assumption?
Just to
So what we have seen with in our institution with the third generation.
There is no AI though.
Edwards S3 valves.
उसमें
If they
दिखाओ.
need
4
pacemakers,
chamber.
it's within actually a day, 24 hours.
So we will keep the pacing for a day.
No, I don't think. I mean, no, I'm saying that.
You
if they
don't think
need-
so?
I don't think so. This patient has sinus rhythm. PR interval is normal. Narrow QRS complex. We don't keep a pacemaker. If anybody has left bundle branch block, PR prolongation, we leave the pacemaker.
Brilliant.
And if it is Evolute Pro, that actually we leave it for about at least 2-3 days if they develop it.
Okay.
Okay, wonderful case demonstration, Dr. Chandra, Dr. Arneja, and Dr. Chouhan.
Thank you.
Thank you very
Thank
much.
you.
Appreciate that.
Thank you. Thank you.